Hi, my name is Amir Dixon. I'm the program manager at Connected Boston, which is a program of the Multicultural AIDS Coalition here in Boston. I'm also a writer and a filmmaker as well, and I'm proud to be joined by two colleagues. Angela?
Hi, I'm Angelo Lima from Fenway Health.
And I'm Dwayne Stewart. I'm the Community Engagement Coordinator for the Fenway Institute at Fenway Health, and I'm also the Community-Based Prevention Manager at Fenway Health in the Prevention Department, and also just a community organizer for many, many years.
Amazing. So I guess we'll start with, so here at CROI, which is being held here in Boston, the CDC released some new information among different subpopulations. So HIV diagnosis within their lifetime by their subpopulation. So 1 in 2 Black MSM will get an HIV diagnosis within their lifetime. 1 in 4 Latino MSM will get an HIV diagnosis within their lifetime. And 1 in 11 white MSM will get an HIV diagnosis in their lifetime. So where are we going wrong? That's the million-dollar question. Where are we going wrong? And what is it that we can do to get PrEP out into the community? How can we have those conversations? How can we do better outreach to the communities? What are your thoughts?
Yeah, I mean, it's very shocking to kind of hear that because I've been working in HIV for a very long time, and when I first started, we were hearing in Black communities in general that there was like 1 in 6 Black men were getting HIV. Then we were looking more specifically at MSM. It was around, I think, 1 in 5, 1 in 4, and now we're at 1 in 2. So we definitely are seeing a trend downward when it comes to Black MSM, and all the research is showing it has nothing to do with promiscuity. It has nothing to do with not necessarily someone's, the moral code that our society likes to revolve around when it comes to sexual behavior. It's really about our lack of public health response when it comes to this. And so it's very shocking to me. It's interesting that PrEP has become a part of the conversation, but we are statistically seeing a lot of uptake of PrEP. And for those who don't know, pre-exposure prophylaxis, the once-a-day pill that you take to prevent HIV, we're seeing a lot of uptake within white affluent communities, mostly because they can kind of afford it. They have the insurance. Now that we have the Affordable Care Act and some other things, and there's the Gilead is offering help with
Co-payments.
Yeah, co-payments and that kind of thing. We're seeing some help in helping kind of break down some of those barriers. But the education is just not as it has been historically throughout all the time that I've been doing HIV research. The education, whether it's about PrEP, whether it's about condoms, whether it's about risk reduction strategies, is just not making it to these marginalized populations.
Yeah, no, I totally agree. When I read those statistics, I automatically thought about many of the clients that I see on a regular basis, young Black gay men who are getting HIV diagnosis at 16, 17, 21, 23. And I start to think about what are some of the structural barriers that they face, right? The structural barriers of housing, the structural barriers of lack of access to healthcare, community-based organizations, community health centers not being in their neighborhood. Oftentimes I'm finding that a lot of providers in poor communities not being knowledgeable about PrEP and not wanting to prescribe PrEP to clients who are the most at risk. And for me, I feel that we have to start to look at accessing treatment and prevention as equity. And I think that we have to center that. And, like you said, we've done a lot of talking around. People say, well, it's a promiscuity thing. They need to stop. They need to stop doing these things. And it won't be an issue, but understanding that there are larger structural barriers that continue to go unaddressed.
Yeah, I mean, to me, what comes to mind very fast when we talk about structural barriers in this country is the fact that regardless of how you're looking at the healthcare system, it is a system that was not built for us, right? It was not built for people of color, and in fact, it was built against us, right? And I think the problem here is that we are trying to we're trying to assimilate into a broken system. and figure out better ways to work at our level, whatever level we have access to, right? But there's only so much community-based organizations can do. There's only so much that the people that are out there doing the work honestly can do. And I think it's time for us to start talking to the people higher up there, right? And asking them, or not asking, but showing them. Asking hasn't done anything for us, so maybe showing them that okay, this is where the problem is.
Demanding it,
Right.
demanding it. I also think that something that I feel too often in the work as providers and as service-based providers, we have to look at and see healthcare, our health outcomes as a civil rights issue, and understanding that, you know, we have to be able to fight and fight hard and go against the norm to do that, right? Because, like you said earlier, the statistics started at 1 in 6 and it became 1 in 5. Now we're at 1 in 2. And clearly there is something not happening, and there's clearly work that needs to be done. And why is it that we continue as Black and Latino MSM, why is it that we continue to be pushed to the back of the line? Why is it that we're continuing to be forgotten? Why is it that we're continued to, like, we have structural barriers set up in our way and they're not being addressed in an effective way with action-based solutions?
Yeah.
You know?
It seems like, sorry, my train of thought just disappeared, but it seems to me like the problem is our communities are not told that healthcare is a right. And I think for the more affluent community in this country, that is it's common knowledge. You know, I think us that are doing the work, we can say the difference between someone from a community of color coming in looking for help and someone from one of the more affluent communities coming in looking for help. And it's like one community comes in having no idea what their rights are, just sort of, you know, please help. Another community is very demanding of what they know their rights are. You know?
Healthcare shouldn't be a privilege, but it should be our birthright.
Yeah, definitely. I mean, and we need to be more involved in this work upstream. So,
Exactly.
I work in the Family Institute where we do a lot of research, HIV research. We're here at CROI, where it's all about the newest research that's coming out when it comes to HIV and the science behind it. But how many HIV researchers and scientists are people of color?
Exactly.
And also, and I know that the work that I do with the HIV Vaccine Trials Network and some of the other networks and with the other scientists, they are talking about how we get more folks into being involved with this work, but then we're not talking about, there's a full systemic oppression picture that keeps that from happening. Lower education issues, access to education, and so we unless we're not only saying we're going to be putting more money into HIV research, we're going to be putting more money into scholarships for youth to go to school or to get the degrees that they need to be involved. And I mean, there's just so many systemic oppressions that we have to deal with in order to even begin to talk about how we decrease the infection rate among Black and Latino MSM populations. And even more specifically, we need more research that is specifically geared towards MSM, especially when we're talking about PrEP. There was the iPrEP study, which now we're studying after the fact the amount of African American and Latino MSM that were involved in the study. iPrEP was the study that kind of really was the groundbreaking study that led to PrEP, to PrEP access in our country. And we're also looking at transgender women. There have just been research done about the transgender women that were in that study. And there were quite a few. I think there was like 360 something.
366.
Yeah, transgender women in that study. But when you dig down into the research, the numbers actually show that the PrEP efficacy wasn't the highest among trans women, mostly because it kind of we don't know for sure, but it was counteracting against maybe the female hormones. But we need more research so we know why. We know those details.
Yeah.
We know how it actually, what is actually happening within African American and Latino populations when it comes to PrEP. And when that research is done, we can then come out better educated on how we can address it.
No, I totally agree. I recently heard Dr. Keith Green, a Black gay researcher, say very explicitly that if we're going to be doing work with Black MSM and trans women, specifically trans women of color, around PrEP and research and all those things, we have to have people from that community represented. And I feel like that is not happening, you know, and I feel that a lot of times we're having people come into our communities and are saying this or saying that and creating and making decisions for us, and we're not at the table. You know, earlier I heard you talking about community focus.
Community participatory research or community action research.
Can you talk about that?
Action research. I mean, it's just it's a type of research that really takes the community and sort of hires them to be part of the research, to be part of the conduction of the research, not just to be involved, you know, in making it happen and in the outcomes as well. And it, you know, it seems to be really great because first of all, it's generating jobs, it's generating education. It's really a more holistic approach to research, I think. You know, a lot of times it's just us coming in big white coats and looking around, right? And instead, we're actually uplifting people, uplifting communities, educating them, empowering them, teaching them, giving them the tools and teaching them how to use them. I think that's something that should be used a lot more often than it has been, because there isn't a lot of it that has been done.
It's happening, yeah, I totally agree. So we talked a lot about the problem, and we set the ground for the problem. And in the next segment, I'm going to talk more about solutions and recommendations. So that's our first segment, and thank you guys so much. And again, my name is Amir Dixon, and thank you guys for joining us.